is inherently academic, political. I come from a long line of political disruptors. And I would characterize myself academically as leaning very heavily on post-colonialists. Um, thinkers like, thinkers like Edward Said and Frantz Fanon have very much informed the way that I carry myself in academic space. So with that, we'll get started with our topic at hand. That was the about me. I have to remember to flip slides. I get carried away with talking. So before we get started, I just want to say that we're going to be talking and touching on some pretty heavy instances and pretty heavy examples of Islamophobia. And so I just want everyone to be a little bit aware as to how their nervous system is reacting to some of those instances, especially if you yourself have experienced Islamophobia or have some relation to the examples that I'm going to be providing, because they are inherently violent. And really, it's, I think, a testament to how much Islamophobia there is in Canada, for lack of a better word. But just to kind of give everyone a little bit of a heads up, and that I won't be offended if you have to take your leave. And to just be mindful as well after we finish this conversation as to how you're feeling, and yeah, just to do what makes sense for you in that moment of wellness. So starting pretty simply, starting it off, what is Islamophobia? So there are a couple of different definitions and concepts that I want to bring forward, but first, it's an unfounded hostility towards Muslims and a fear or dislike. It's also a prejudice, aversion, hostility, or hatred towards Muslims, encompassing any distinction, exclusion, restriction, discrimination, or preference against Muslims that has the purpose or effect of nullifying or impairing the recognition, enjoyment, or exercise on an equal footing of human rights and fundamental freedoms in the political, economic, social, cultural, and any other field of public life. That's a lot of words. Point is, it's a hostility towards Muslims that leads to our exclusion and our inability to fully participate without fear of repercussion. It manifests in a number of different ways, which we'll also be talking about in a minute. There are examples of physical assaults, verbal abuse, vandalization of property, discrimination, depictions of literature and media. I also really want to convey, and we're going to be talking about this further along as well, it's often gendered. And the reason for that is a lot of Muslim women, like myself, wear the hijab. So we are particularly identifiable. And so there is often a gendered element to Islamophobia. It impacts not just Muslims, but also those who are perceived to be Muslims. And this I always found slightly entertaining, that it's an ignorant, a deep ignorant form of hate. So the example is that a lot of Sikh men, especially those who wear the turban, are often mistaken to be Muslim. So a great example is Jagmeet Singh, the federal leader of the NDP, is often fending off Islamophobic instances, even though he himself isn't Muslim. But those are still examples of Islamophobia. So it's really this deep-rooted ignorance of who we are. And like I said, it prevents Muslims from fully participating in society without fear of personal or structural violence. And so again, we're going to be kind of piecing apart what interpersonal and what structural violence looks like, as there's a bit of a distinction there. But that's kind of the working definition that we're going for, or that we'll be talking about in general. So kind of setting the stage in Canada, which I find particularly important when talking about Islamophobia, is just the extent of Islamophobia in Canada. I don't think people really have been aware. Maybe they have, I don't know, but more Muslims have been killed in hate attacks in Canada than any other G7 country because of Islamophobia. So the G7 is an informal group of the 7 countries with the world's largest economies. And so Canada, Germany, UK, France, Italy, Japan. And so out of all of those countries, all diverse countries, all have, booming economies, Canada is the most lethal to Muslims. And really, it's just, I think, a really quick way of presenting a snapshot of just how insidious and how in-depth Islamophobia is in this country. And while the instances that I'll be talking about in a second are far and wide across this country, it really, I think, demonstrates the extent and just how pervasive it is for most Muslims have encountered it in some shape or form. So, talking about Islamophobic violence in Canada, these I think are some, again, really important examples to bring forward to demonstrate just the extent of Islamophobia when we're talking about of what has happened and really what life has been like for most Muslims in this country. So there are several of really important incidents that have, I think, shaped the perception of Muslims and also Muslims' feelings of belonging and safety in Canada. The first of which I talk about is the Quebec mosque shooting, which occurred in 2017, which killed about 6 individuals and injured several others. This individual in this incident was then later inspired copycat, I would say, in Christchurch, New Zealand. And there was another mosque shooting where 30 worshippers in the mosque were killed. There was a stabbing of a mosque caretaker in Toronto in 2020, and then the Afzal family attack that Shikufe also mentioned in 2021, right here in London, killing 4 family members. And throughout this time, there have been violent attacks on racialized women wearing hijab. I can think of a series that were occurring in Alberta throughout also 2021, 2022, were specifically Black hijabi women who were being targeted throughout the province of Alberta. But in general, I think as a visibly Muslim woman, I would say most, if not all, of the women wear hijab have some kind of instance or another of being verbally assaulted at the very least, if not more than that. So again, it just, I think, demonstrates the extent of Islamophobia, its lethality, and the instances of, just really shaking the Canadian Muslim community to its core in terms of our general wellness, but then also our sense of belonging and safety in Canada. So that's the interpersonal. But I think it's really important to talk about what structural examples are as well. Again, to really send home this notion that Islamophobia isn't just about interpersonal violence, it's also about structural violence. And what does that look like for Muslims living in Canada? So there are a couple of different examples. Bill 21 in Quebec is probably the most common examples. It's the Religious Symbols Act, where anyone who wears any kind of religious symbols is not allowed to be a public servant. That includes teachers, judges, police officers, etc. It doesn't just affect Muslim women, but affects Sikh men, Jewish men who wear a yarmulke, etc. Its predecessor was Bill 62, which prevented women who were wearing niqab from accessing government services. So there has been this consistent targeting of Muslim women in Canada in terms of their attire. We have constantly, our dress has been a topic of debate in several election cycles, which really just feeds into the consistent violence that we faced. There is also examples of the CRA disproportionately auditing Muslim charities and the subsequent, again, disproportionate removal of nonprofit status that has been occurring over the last little bit. And then national security measures that target, surveil, and limit the rights of Muslims. There is an example of no-fly list. So this photo on the right here is no-fly list kids. So it's kids who share the name, Arabic, Muslim-sounding names with people who are on terror watch lists. And so they themselves have been put on no-fly lists, and they essentially can't get on a plane. So these 8, 7, that I think one of the kids is 5, they're on terror watch list because they have a Muslim sounding name. So these are examples of things that are happening in Canada that I don't, again, different levels of awareness. And last, but definitely not least, CISA's intimidation and discrimination, especially post 9/11. We had the targeting and the surveillance of Muslim communities in this country. And so systemic messaging, I think, is really important because it sends a message to the rest of Canadians who might have varied interactions with Muslims and Muslim communities that, surveilling, criminalizing, stigmatizing Muslims is okay. And that includes our healthcare workers and our healthcare professionals who are hearing these messages and who are giving these examples of saying, maybe these Muslims, they're not so great, maybe we should be treating them with suspicion. So when the messaging is coming from our highest levels of government, it affects the rest of the population and the way those individuals also perceive and treat us as well. And the last, I think, thing I really want to touch on is pop culture and media. So this is really one of my favorite examples because who hasn't seen the movie Aladdin, right? We've all seen Disney's Aladdin. It's a great example. I think one of the first songs in the movie is just about how like terrifying and violent Arab-ish sounding and looking people are. And so it's a really great example of Orientalism, which is a concept that I lean heavily in my work and I think is really important as we kind of talk a little bit about how Muslims are perceived and understood in space. And so Orientalism is a concept by Edward Said, and he defines it as based in the Western's historical and contemporary power to produce knowledge about the Orient or about, I guess, the Eastern world in the form of reductionist fantasies and negative stereotypes. And so some of those stereotypes is what we see in the movie Aladdin. But they're really produced and reproduced in pop culture and media. And so a lot of those stereotypes are about Muslim women being meek and about being like helpless, whereas Muslim men are aggressive, scary, violent terrorists, right? So really reductionist perceptions of Muslims that are produced and reproduced in cultural media. And again, the pervasiveness of this causes the general average individual in this country to perceive us and understand us in a very specific way. So these depictions in policy and in media contribute to the interpersonal violence and the type of discrimination that we are at the receiving end of throughout our lives. And again, that includes healthcare spaces. So getting to kind of the meat of why I'm here is to talk about Islamophobia in healthcare. So there are a number of different ways that that kind of manifests. And I talk about micro and macro aggressions just to kind of differentiate the different types of Islamophobia or the different types of discrimination that Muslims have faced or do continue to face. When we talk about macro aggressions, we're talking about identifiable moments of racism, right? We're talking about slurs being used, about, comments being made, examples, did not finish the sentence, obvious but not unheard of in Canada in healthcare spaces. And so they're not uncommon, unfortunately. Even in my own research, which Shakoufe also mentioned, I talk about to Arabs how they're navigating the healthcare system. And quite unfortunately, there are comments being made about hijab, about its questioning its necessity, looking down on the practice, statements being made about you people behaving in this way or that way, dismissing reports of pain, which are far more recorded to happen far more with racialized patients. And then misdiagnoses, which I think really it gets down to the malpractice element and the mistrust in the healthcare system that a lot of racialized folks feel when they interact in healthcare. So the example in this publication that was given was the doctor had some preconceived notions about the color of my skin. And by looking at my family that I might have traveled to Pakistan or India, he was convinced that I had malaria and kept looking at an infectious disease perspective. And so this was an individual who was later diagnosed with cancer. And there was a delay in that diagnosis because of really the racism or the assumptions that were being made in that healthcare setting. So again, macroaggressions, we're looking at overt comments being made. And again, just not uncommon, unfortunately, as much as we would like it to be. When we talk about microaggressions, so these are a little bit more difficult to identify a lot of times. This comes with the assumptions and with the feelings of being treated differently. And so they're called micro because they're not obvious. You're not being called a slur. But a lot of people have made the argument, and I would as well, that micro is not so small because when you accumulate those microaggressions over time, the load gets to be quite big. And so there are lots of assumptions about female patients, again, especially about those wearing hijab, about their agency, about their education, about their proficiency to advocate or to make decisions. There are assumptions made about language capacity or about where individuals are from. And really just this general feeling about being treated with less courtesy, respect, and attention. And I think a lot of individuals who are racialized have had experiences of like smaller microaggressions in various spaces. But this is just, some of the ways and the examples that they are manifest in healthcare in general. And that brings us to a really important concept that I really like to talk about when we're talking about racism in healthcare, and that's the example of perceived discrimination. And so perceived discrimination is this notion, again, you're not being called a racial slur, but you're feeling as though you are being treated differently in space. And so is it an overt example of racism? Not necessarily, but the perception of the person on the receiving end is of racism. And I think, again, like some racialized individuals can attest to, I myself have been at the grocery store, for example, where the cashier is really smiley, really interactive, really cheery with the person in front of me, a white person. And then she gets to me and she's stoic and a little bit standoffish. Is that an example of racism? I don't know, but I am on the receiving end of that, and it kind of feels like it. And again, because of the pervasive nature of Islamophobia in our culture, in our policy, in our media, sometimes that it is. But again, it's not an overt example. What perceived discrimination tells us, though, is that it demonstrates that an explicit act does not need to take place for individuals to feel as though that they are being discriminated against. And so these subjective experiences still had a negative effect on psychological well-being, which I think is really the important part here, is that people were still feeling as though they were being discriminated against. And it really manifested in this notion as they were feeling as though they were a receiving end of an attitude accompanied by subpar care. So this, again, is where people are starting to feel a mistrust in the healthcare system and with their healthcare providers. So they have feelings of being treated like an outsider, feeling misunderstood, and it causes a reluctance to seek help because of that mistrust. There are assumptions about what services Muslims would or wouldn't be interested in. For example, mental health services, making assumptions about whether or not people would use them, and so they're not offered at all, and it includes antenatal classes as well. And just the lack of awareness of religious practices, the needs for prayer, and ablution or I guess hygiene practices as well, different privacy for different genders, and food options as well. And so again, it's this notion of feeling as though you are being on the receiving end of discrimination, and that overall impacting people's trust in the healthcare system with their providers, and also having an overall negative effect on their psychological well-being. So I think the examples of what's bad or what's wrong is really important, but I think it's also important to talk about what do we do, so that we're not just harping on the things that are wrong. And so I was really happy to hear in the introduction talking about cultural humility, which I think is a fairly important concept and one that I think is getting a little bit more attention these days. I like to contrast cultural humility with cultural competency, which I think has been talked about quite a bit. So cultural competency is like teaching segments of another person's culture, customs, practices. But it really poses us with the difficulty of how much of another person or the other can be understood. And it falls into the trap oftentimes of creating caricatures to explain another person's culture. And so, I've seen, cultural competency training on Muslim patients, for example, which I think is a good start to have a general understanding. But I am so much more than points that can be put up on a slideshow. Right? Like my whole life, my existence, the way I see the world, that whole paradigm of existence from the culture and the community that I live in cannot be explained in a half an hour. And so that kind of problematizes this notion of cultural competency. It can offer maybe some familiarity with communities that are new to us, but I think it's insufficient. And I think this is where cultural competency or cultural humility, sorry, comes in for us, because it calls healthcare professionals to be introspective on their own cultural practices and biases. So instead of trying to learn about the other, cultural humility calls on us to look at ourselves and what biases we may carry, and just what understandings we have about ourselves and the way that we navigate in space. And so in the way that I was talking about positionality in the beginning, it kind of offers the same thing, not just in academia, but also in healthcare spaces. It's characterized by self-awareness, by self-reflection and critique, and focuses on identifying and examining an individual's values and practices. And so we're really sitting with ourselves in that moment to say, what are our own values and practices that we bring to healthcare spaces? And how might those be a barrier to providing equitable care for everybody, not just necessarily Muslims, but to other people who may not share those same values? Another really good example, I think, of kind of rectifying or changing course a little bit is culturally affirming practices. So I bring up this example of a local organization that I really, really love working with. It's not Muslim specific. It is racialized and has done work with Muslim groups, including community groups that I work with. It's called Type Diabetes. And they work on providing culturally affirming diabetes care. So it's really this notion that food is a cultural and community bonding experience, and it's not just for sustenance. And so when we're asking people to eat healthy or maybe to change some of their food practices, perhaps for diabetes or for just in general to watch out for their health, that sometimes we're asking people to let go of parts of their cultural and communities. And that really has an impact on how much people feel as though they can adhere to those health plans. So instead, how do we affirm people's culture in space and to ensure that they feel as though they can bring their whole selves to their healthcare practices that they're being asked to adhere to? So my friend Mystery Furtado, who runs this particular organization, talks quite a bit or does diabetes education to say, what are your cultural foods that are important to you and that you enjoy eating and that, you know, really bring you a lot of fulfillment in life? And how maybe can we modify them in ways to stick to the health necessities that you have? And so it really says, you know, eating healthy doesn't have to be bland. It doesn't have to be letting go of your cultural foods, but it's a matter of how do we ensure that those foods are really healthy for you. And so just affirming people's cultural practices in space. So that's one way of really asking people or making it accessible for people to bring their full selves to the fore, is really ensuring that their cultural needs are being understood and affirming those cultural practices as we go along. The next example that I have is also another example that I hold fairly near and dear to my heart, and that is the Muslim Resource Center for Social Support and Integration, another local organization here in London that doesn't just work specifically with Muslims, but anybody who really comes from a more collectivist culture to offer support for those individuals in community. And so it's, again, this notion of integrating individuals' culture into those healthcare practices and to see how we can support individuals as a community. And so a lot of individuals from Muslim communities, we come from collectivist culture. Health is not an individual concept. Healing is not an individualist concept. And so bringing community to space is also particularly important. And so organizations like the Muslim Resource Center do a really good job of explaining what that looks like and providing models. In this case, a lot of the models have to do with psychological care and social work, as well as gender-based violence work in community. And so what does healing look like in that space? What does family safety look like in that space? And what does health and general well-being look like in a really culturally integrative approach, and ensuring that, again, a person is able to bring their full selves to their understanding of health and wellness. And so this integration of culture, this integration of community into health and healing is particularly important, again, for this organization and in general, and to ensure that people are supported in their full selves. So again, a number of different organizations that are doing great work. I think other examples of both culturally integrative and culturally affirming practices are things like, you know, gender specific sports, you know, or recreation facilities. I know that there are several of those that exist in London that help Muslim women stay active or feel as though they can participate in sport and leisurely activities, and really just understanding overall what people's needs are to, again, feel like they are safe in space to be able to bring their full selves to the table. So that's my talking portion. I wanted to cover both what was, I guess, problematic in healthcare spaces, but also some examples of some really good work and examples of how people and organization are working to solve some of those blind spots or some of those areas that need work. And with that, I guess I'll turn it back over to Shifupeh for questions.
Thank you so much, Salma. It was amazing. And I really liked it that how you brought all those critical perspective, that theory aspect of what is happening in the context of Islamophobia And I really loved that you brought Orientalism into this, because it's always helpful to know the roots, that colonial legacy that we are perpetuating.
Mm-hmm.
And with that in mind, I'll open the floor to questions. Please raise your hand if you want, or unmute yourself and ask a question. Maybe Salma wanna stop sharing the screen that I can. Yeah, that would be great. Thank you.
Thank you.
Okay.
I have a question. I'm a physiotherapist. My name is Yaro. Salma, is there any specific advice for physiotherapists? I know there is a huge in-group diversity, so you can't speak for everyone. But are there any common things that should be observed in physiotherapy setting?
Yeah, I think you are right in saying that people are diverse in their preferences and needs, and so really taking a patient-led understanding to what that patient is comfortable with in that space and in that moment. People are comfortable with different levels of, say, gender interaction, or with different levels of physical contact. And so just really being mindful of that in that space as to what that looks like. And I know, again, I think this has come up quite a bit in the literature and in people's experiences, specifically with Muslim women who may not uncover in front of men. And so depending on what the body part is that's being remedied, is just ensuring that that comfort level is being respected. And a comment that was made a while back that I heard, and now can't remember where, but it was just about this notion of accessibility, that if somebody has to ask for an accommodation, then it's not actually accessible, because you're putting that person in the position of asking, of having to advocate for themselves. And so really just across the board, making sure that it's known that these accommodations can be made. And so people have the option of opting into it instead of finding the need to vocalize their needs themselves. So.
Thank you. Let me rephrase it a little bit. Is there anything in the, because I understand that we are all genetically identical. The differences in upbringing, in belief systems, and is there anything for this community that would be consistently requiring a different accommodation, or it's just the general sensitivity and offering all the options as to everybody else?
Yeah, I think that, again, it's a matter of just understanding what individuals' preferences are in that moment. And so I don't know if I can make any sweeping generalizations about needs,
Okay.
but yeah.
Okay, thank you.
But
That
thank
answers my question. Thank you.
Perfect.
Thank you. Thank you so much, Jaro, for your questions. I think it's that was a great addition that about accessibility, because I do also remember being a community health nurse, that in the vaccination clinic we had this problem that any client that come from the Muslim background, I had to go to the leader in this clinic to ask for a private room for them to do the breastfeeding, because we wanted to implement breastfeeding before vaccination for reducing the baby's pain. So if the design of the clinic is like that there is no private room, it's adding another layer of discrimination. Okay,
I think that's a great example.
Yeah.
And I actually got the first dose of my vaccine. It was in a mosque. And so they had kind of a side space for Muslim women who weren't comfortable getting their vaccine out in the open. And so that's a really great example of just a design where women did not have to ask or advocate for themselves. And it was just designed in space. So.
Yeah, perfect. Yeah. Shahnaz, go ahead, please.
Hi, Dr. Hello, Salma. I really appreciate your talk. It was very insightful. Thank you for that. I just had a question regarding, you beautifully talked about cultural competency and cultural humility in terms of, like the literature nowadays is more of focusing on cultural safety instead of more towards cultural competency, right? Again, it's focusing on the cultural humility aspect. So I just wonder, and the universities, like if I talk about Western, because I'm quite new here, So I learned that we have the EDI, like equity, diversity, and inclusion stuff going on, but I really can't find the application of it. I mean, there is a disconnect. What I have perceived within my 1 year of experience of being here as an international student, I really would like to have your insights, like what one thing could be proposed to promote that. I mean, that should be something in action. Am I clear with the question? I don't know.
No, I think it's a valid question. I think and maybe I'll come at it in a different way a little bit, is I think part of the response to Islamophobia in space, but really even just racism and discrimination in various spaces, including in healthcare, is advocating for Muslim or diversity in leadership. And not just external diversity, but also internal diversity of thought. And so I think, promoting or, even just like universities being aware of the student cohort, of their cultural diversity in the makeup, and so that we have healthcare professionals who come from various backgrounds. And similar in the university, seeing taking a critical eye and a critical lens as to what the leadership of different organizations look like, so that we can kind of bridge that disconnect between what the EDI or what the plans we want and what some of those structural changes we want made. I don't believe in, I guess, a tokenistic diversity, because I don't believe that simply changing the color of the faces around the room is going to be sufficient change. It has to come with a diversity of thought that enables an identification of some of those structural changes that need to take place at the same time. But I think that those kind of go hand in hand. And so really just, questioning, who gets accepted in what spaces and what voices are heard around the table, I think is part of that really important questioning that has to happen.
Thank you so much. Thank you.
Thank you, Shahnaz, and thank you, Salma. Sarah, go ahead.
Hi, thank you so much for your presentation. It was very informative and well thought out. My question is not, I guess, super on topic, but back in one of your slides, you mentioned that Muslim charities are targeted more by the CRA for auditing. And I absolutely believe that to be true. Like it at face value makes sense. And I totally believe that. I'm curious though, if you have like a sort of a solid reference for that, so I could share that with other people, should they not believe lived experience over like, a news article or something.
Yeah, no, there's a report. There's actually a report that came out. I believe it was the University of Toronto, I think, that came out with a report that was actually looking at the number of charities that were being audited. And so this, it actually was as a result of post 9/11 legislation that kind of created an arm of the CRA to ensure that there wasn't any terrorist financing happening in these charities. And so, again, legislation that really criminalized, surveils Muslims in order to, really with this stigma in the post 9/11 world that we live in. But yeah, there is actually reports that have come up that have even done the statistical breakdown. I believe it's University of Toronto, but I can quickly look it up as well as we answer other questions.
Thank you so much. That's great.
Yeah.
Thanks.
I think that's a great question, and it's very important to know that there are evidence of discrimination happening in the policies, in the programs at the higher level, and there is this I don't know, stereotypes, or there's this understanding that these problems are US problems. These are not happening in Canada. Canada is multicultural. There's this shallow promise of multiculturalism in Canada. So having that, seeing that in a policy and seeing that, okay, this coming from a higher level, it shows that we're not way far behind what's happening in the US. Okay.
I just looked up the report. It's titled Under Layered Suspicion, a review of CRA audits of Muslim-led charities. And so that has a full report, an executive summary as well, that kind of details some of that information.
Thank you. Megan, go ahead, please.
Hi, you guys. Thank you, Salma, so much for your presentation. And I just wanted to, I'm kind of coming from a couple of different perspectives here. I'm a social worker. our code of ethics recently got an update that put even more explicit language around promoting social justice and respecting intersectionality and things like that. So that was a welcome change to our social work, social service work code of ethics and standards of practice. I recently became a co-chair of an internal committee here at St. Joseph's Healthcare London, which is called the Cultural Humility, Equity and Safety Committee. So I just wanted to mention that to this group of people, that it is an open committee. It's started in Parkwood Mental Health last February, but has since expanded to be welcoming of staff and care partners associated with the organization at any site. So when you were talking, Selma, about the idea of cultural humility and really kind of putting the focus on ourselves and really looking at our social locations individually and figuring out what they are in relation to all of the people that we're working with and caring for as healthcare professionals and that kind of thing. And then just in our own personal lives as well. The committee so far has sort of agreed that awareness of the committee and awareness of issues like oppression and intersectionality and cultural humility are sort of the first interest of the committee to kind of promote external to, like, throughout the organization, essentially. So I just wanted to mention that if anybody on the call is interested in hearing more about that committee, being on our email list, being invited to meetings, they're typically once a month. Our next one is actually tomorrow at 11. But even if you're completely unavailable for that, if you're interested in hearing more about that committee, please send me an email. My name's on the screen there. It's megan.mcmaster@St. Joseph's Healthcare. You know the email address. My co-chair is, our co-chair is Zan Salimi, who I believe is quite involved in that, the second, I don't remember the full name, but the Muslim
Resource Center. Yes. Yeah.
Yeah. So he's the other person that people could email to sort of express their interest. And I see
I just wanted to say, if
McCowan, so
anyone
I'll
knows,
certainly add that person.
Sorry, I just wanted to interject and say, if anyone knows Zan or is close to Zan, his father-in-law recently passed away. And so just wanted to put that out there if anyone knows him. Yeah. So
I didn't know that. I'm sorry to hear that.
Mm-hmm.
So yeah, I think I wanted to basically tell everybody on the call that, and I got your name, Ashley, so I'll add you to the list. And also just say, like it said in the bio that you work at Intercommunity Health Center, Selma.
Mm-hmm.
So at some future date, I might reach out to you to talk about possibly coming to that committee to do some kind of presentation, if you'd be open to that.
Sure. Yeah, absolutely. Yeah.
Thank you so much.
Yeah, thank you.
Thank you so much, Megan, for bringing that into our attention. Yeah, anyone who's interested, please contact directly Megan, and then she can advise on what would be the best approach. Okay, Jack, go ahead, please. Ask your question.
Hi, Selma. Thank you for the presentation. I thought it was really eye-opening, and I just wanted to say that as a person of color, of a marginalized group, I think it was really eye-opening to see how different our experiences can be. And I think that's really opened my mind to thinking about how, each of our experiences are going to be very unique with these issues of discrimination and prejudice. But one thing I wanted to ask about was, you mentioned the diabetes program, type diabetes. That's
yes, I can put it in the comments. Yeah.
Yeah. So I thought that was really interesting and really cool, because I think when we're learning about nutritional education, I'm in nursing, nutritional education around diabetes, we don't often learn how we can integrate cultural diets into that sort of nutritional education, and how we can adjust that to fit with our care planning, right? So I'm wondering, within the structures of a hospital, for example, where there's a lot of these different systems and policies that are difficult to shift, how can we sort of integrate, these culturally integrated practices into our care at the individual level?
Yeah, I think that's a great question. I think it comes again from making a space safe enough for a person to bring their whole selves. And so it can just be, if you have, for example, an Arab or an Afghan or a Persian client sitting in front of you, doing a little research and understanding what some of those cultural foods are, or asking the person in front of you as well as to what some of those foods are, and to have a better understanding as to what the fullness of their diet is. And to then use your knowledge as a nutritional expert as to how those what some of those modifications are. And so I think it's a multi-layered process of, you know, making our spaces safe enough for people to feel as though they can bring themselves forward. And this is what I meant in the beginning, I think, by the myth of neutrality, because I think we think of our healthcare spaces as being neutral, right? But I don't think a neutrality exists. I think in Canada, neutrality is the predominant culture, which is Anglo-Saxon Judeo-Christian culture, right? Which a lot of people don't identify with. And so for a lot of people who come into healthcare spaces, that's what's being promoted, that's what's being understood. And so how is it that we then create a space safe enough that someone feels comfortable enough to say, you know, well, my culture is a little bit different and we kind of don't eat those foods, right? How do we create a space safe enough for an individual to feel as though they can, you know, bring their cultural practices forward and they won't be dismissed? And yeah, assimilation is considered neutral. Exactly. I think that's a very important point to be made. And so, yeah, just kind of asking those questions. And even, you know, I've seen healthcare providers even do their own research to try to understand the fullness of the person in front of them, so that they can assist with making some of those changes in a culturally appropriate way. So. Jack, did you have another
Amazing.
question? I saw you put your hand up.
Yeah, I did have one more question. So
yeah.
I think one of the ideas around cultural humility is having the space of, you know, like approaching the situation from a place of unknowing, right? And allowing yourself to learn about this person's culture and their practices. So I was wondering, and I know that sometimes when we're sort of trying to learn and educate ourselves about different cultures, it can be sort of burdensome and putting the onus on the person part of that culture to teach you, right? Yeah. So I'm wondering, let's say like in a patient interaction where you're not necessarily very educated about their culture and their religion, for example, how would you go about, you know, trying to learn more without being too burdensome or, you know, making it feel like it's on them to educate you?
Yeah, no, I think that's a great question. I think that's a really important point, that the burden of education and advocacy really is on often the people who exist in marginalized spaces. But I think what I've found is people like to talk about themselves. People like to give, you know, talk about their cultures as well. People like to talk about where they've come from. And so when we pose the question of just who are you as an individual in wholeness, I think that goes a long way to say that I care about you as a person. And so it's less, can you teach me about, you know, 1, 2, 3, but more so, who are you and how can we make this space safe enough for you so that you can reach your optimal health? And really, I think that connection goes a very long way. In some of my research for my dissertation that I was doing, a lot of the Arab senior immigrant clients or patients would talk about their relationships with their family doctors. Their family doctors didn't speak Arabic, didn't understand the language. They would sometimes have a translator in the room, but not always necessarily. And they just loved their family doctors because the doctor went above and beyond in making them feel as though they paid attention to them, they cared about their health, they cared about their cultural well-being and their safety in general, and tried to understand and to learn where the patient was coming from. And so I think, again, just approaching this person as a human, you know, in general, how do I learn and understand about you so that you can, again, you know, reach your best health, I think goes a long way. And people see that and understand that. And when they feel safe enough to bring themselves to that space, I think that's how that learning happens. And you're absolutely right. I think cultural humility is about looking at ourselves and to say, what biases maybe do I hold about Muslims, right? Like, you know, what kind of perceptions do I hold about Muslim men being violent and aggressive, about women being oppressed and meek and incapable of advocating for ourselves? So it's about kind of that introspection of the biases and the understandings that we carry, and how does that affect the patient sitting in front of me?
Great, thank you.
Thank you both. I think that's, I mean, this is very basic, but that's a lot of, speaking of biases, very common stereotype that I get as someone who grew up as Muslim but not Arab is that all Arabs are Muslim or all Muslims are Arab. So the distinguish having this too, that not all Arabs are Muslim and not all Muslims are Arab, it is very basic, but have that in mind to not perpetuate that stereotyping and let people to be the voice of their values, their preferences. That's I think we should advocate for. And also I wanted to add, like as nursing, as going back to that neutrality that you were talking about, in nursing as a highly regulated profession, it became a kind of a standard of the work and the practice that nursing became a political profession. And they don't want to get engaged in anything that's related to maybe sometimes social or political aspect of care. And they feel like, oh, that if I say something wrong, that might put my license at risk or my practice at risk. So I know you talked about it, that how everyone can be more active and stop with that neutrality, but also for a systemic change, that when you are a nurse in the system, what would you recommend for nurses to get their hands on that advocacy work, that activism, that integrate that activism into the part of the care, and the care doesn't stay in the biomedical model of care, and bring that social political aspect of care part of the intersectionality of the individuals?
Yeah, that's a difficult question. I think I can speak from my own experiences in activism. I have been very lucky in the sense that the spaces that I work and the organizations that I have worked for do not care how much of a loudmouth I am. And I, at the same time, recognize that not everybody is in the same position, that some people are worried about their jobs and their ability to be activists in those spaces. I think at the same time, we're living in a time that really requires a lot of moral courage of us. And there's a quote, I can't remember who said it at this point, but silence and neutrality is taking the side of the oppressor. And I think really, holding that dear to us, to say that there are consequences to speaking out, absolutely. But being silent, I don't think is an option any longer. And so as difficult as I know that is, depending on where we work and what our jobs are, I think, we're just living in a time that really requires quite a bit of courage of us. And at the end of the day, when history tells our stories, we get to have the satisfaction of being able to look ourselves in the mirror and knowing that we were on the right side of history. So.
Thank you. That's amazing. And Megan, I'm not sure if your hands are up from the last round or you have a new question.
I remember that I did have a question, and I just wanted to comment on the exchange the two of you just had too, that moving away from a purely biomedical model to a more holistic, biopsychosocial, spiritual, etc. model of assessment and treatment does give sort of nursing professionals some social license within the healthcare system, within the medical model system, to incorporate that in an evidence-based way, consistent with the values of their profession as well. So I just wanted to point that out. And then the question that I had, I forgot before because I was in like presentation mode, but is just like, do you have any kind of best practices, like things that healthcare organizations like ours can put in place to systemically invite our patients to share about their cultural things that are important to them culturally in a systematic way, I guess. I'm just curious if you have any knowledge of things that work already, basically.
There's a colleague of mine here that does a really great work around trauma and violence informed care, which I think is really interesting because I was just talking with her not a while back about how to make assessments about what it's like for a patient to come into the space and what every interaction is like for them at any moment in time. And how that might be reinforcing or re-traumatizing people in different places. And so I thought that was a really important assessment, or something that I thought was pretty valuable, because we don't think about how again, going back to this notion of neutrality in space, we might not always think of putting ourselves in the shoes of the patient or in the shoes of how people are received at the point of care. And so kind of working through those assessments and to say at what point are we asking people to advocate for themselves because our options aren't necessarily accessible to them, and asking those critical questions about the systems that we have patients walk through, I think is a bit of an audit almost, but I think can go a long way to say, again, what point are we asking people to put themselves forward instead of making the options readily available.
Thank you. I think if anyone else have a very final question, they can ask. If not, we are 3 minutes to the end of the session, and I feel like this was a very great session. Thank you so much for all your insight, and it was very amazing, very great presentation. You can tell from the number of the participants on this call, it was close to 80 members participated, and also from the engagement in the question, you can tell that it was such a fruitful session for everyone. And we will send you a token of appreciation for your time you spend with us and you share your wisdom with us, and also a thank you letter you will receive from us. And I really appreciate your time, Salma, and I appreciate your friendship and your everything. Thank you.
Thank you so much for inviting me. I hope it was useful and enlightening in some way. So thank you so much.
Thank you. Thank you everyone for being here, and stay in tune for the next speaker series. We will receive the emails on your inbox, and we will have a lot of amazing and exciting speakers and sessions to come up in this year. Bye, everyone.
All right. Thank you. Bye.